Okay, so let us begin. So, as we all know, the topic of this webinar is the essentials of high flow oxygen, right? And what we want to look at during this next probably 30 to 45 minutes is discussing the high flow delivery devices that we all have available in our clinical area. I suspect most of you, and probably all of you, will be the AVA will be the most familiar to you all. We'll explain how high flow therapy works, and we'll also show the setting up, the application, and the disinfection of an AVO in the next half an hour. So before we start, probably just a little bit of background. Is anyone willing to have let me know, like, why do we use oxygen therapy? You think of some of the patients that you've seen in your clinical areas. Why do we use oxygen at all? Everyone's gone shy. Oh, good. So often we definitely for chest pain. I'm sure all of us have seen oxygen being applied to patients who present to hospital with chest pain. And that's obviously to help cell metabolism and cell function. In that, if cells aren't provided with any oxygen, then cells die. And this is obviously vitally important for all cells, but particularly the heart. We also apply oxygen for type 1, so what we call type 1 and type 2 respiratory failure. The difference between type 1 and type 2 respiratory failure is that type 1 respiratory failure is a failure to oxygenate, whereas type 2 respiratory failure is your failure to oxygenate and ventilate. So to put that into a clinical context, your type 1 respiratory failures are normally the patients you see, for example, with a pneumonia or with cardiac failure, whose carbon dioxide levels are usually normal, but they require supplemental oxygen in order for them to be able to, for their cells to be able to survive. Our type 2 respiratory failure are those patients that we see with, I think a good example is probably our COPD patients, where we always see patients with COPD that not only have low oxygen levels, but they also have high carbon dioxide levels as well. There are also probably many other reasons why we give oxygen other than what's on the slide. And some of these can include sepsis. We often see oxygen being given in the various forms of shock, such as hypovolemic shock or anaphylactic shock. We often always give oxygen in trauma as well. So I'm sure we're all very versed in when we give oxygen to our patients. So my next question to you is too little oxygen bad for you? I think we all know that the answer is yes. Too little oxygen definitely is bad for you, and that tissue hypoxia can lead to cell and organ death, and then eventually, if not treated, death of the patient. But the question is, too much oxygen bad for you? The answer is also yes. as we probably all already know. So there's a lot of research that suggests that administration of high concentrations of oxygen can lead to oxygen toxicity. Unfortunately, as yet, we're not really sure how much and for how long these high concentrations of oxygen are delivered at toxic levels. But some of the symptoms to watch out for are nausea and vomiting, hallucinations, and pulmonary edemas. But obviously, these symptoms can also be because of other underlying disease processes as well. But I think the important thing to take away from this is be mindful that delivering too much oxygen in high concentrations over a longer period of time can be bad for the patient. So that leads us nicely on to asking, well, how do we know what the right amount is? And I think this is often a question that we as nurses ask ourselves frequently. And I think really the answer is by monitoring our patients. And this is something we do all of the time. So how do we know what the right amount of oxygen is? If we aim for SpO2 levels between 94 to 98%, we can pretty much guarantee that our patients are getting an adequate amount of oxygen that is not detrimental to them. So the key to this is titrating oxygen flow so that we get appropriate SpO2 levels. I think as nurses and probably as clinicians, we're really, 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 really good at turning oxygen flow meters up, but we're probably not as good at turning oxygen flow meters down. I think sometimes we get a little bit scared to reduce oxygen levels, but in reality, if our patients are oxygenating well and have good saturations, there should be theoretically no reason why we can't begin to bring our oxygen flow meters down. I'm going to pause there. Has anyone got any questions so far? Check that there's no one else in the waiting room. Okay, so let's carry on. All right, so sometimes we see patients who need more oxygen than our low flow oxygen devices, such as our nasal prongs, our Hudson masks, and our non-rebreather masks can deliver. So I'm going to play a video here. I want you to watch the video and decide which oxygen delivery device you think this patient needs.
I can't breathe. Please help me.
So let's have a look. We've got a question. So Team Nauru, with type 1 respiratory failure, mentioned that it's pneumonia. Is it severe pneumonia or how severe? Good question, Team Nauru. Type 1 respiratory failure, it's not necessarily to do with severity, it's more to do with whether the patient is just requiring oxygen or whether the patient is requiring oxygen but also has a high carbon dioxide level. So that failure to oxygenate and failure to ventilate. Does that answer your question a little bit? I think you'll often find with severe pneumonia that it may progress into type 2 respiratory failure. No problem. All right, so with the patient we just saw here in the video, what kind of oxygen delivery device would you apply to her in your healthcare setting? This is not a trick question, and there is absolutely no right or wrong answer. It's more around a discussion. Is anyone willing to have a go? What kind of oxygen mask would you place on that patient in the video? And why? Why are you worried about her? So Veronica in PNG has said using a rebreather mask, and Team Nauru have also said a face mask. And I think, yeah, I think your choices are absolutely spot on. It is obvious that that this patient definitely needs some form of oxygen, and probably the most accessible at this moment in time probably will be a rebreather mask or a normal face mask. Why are you worried about this patient? What signs can you see that make you think, oh, she definitely needs a little bit of oxygen? There's a few clinical factors there that are quite worrying, aren't there? There's the certainly the high respiratory rate. So we know that a high respiratory rate is a really bad sign for deterioration and needs to be acted upon. The patient is also talking in short sentences. Yes, Team Nauru, she cannot speak. She's in distress. She may be cyanosed. Yeah, we can't actually see that at the moment because she has a face mask on. But yes, that's definitely something to consider. So my next question then is, we recognise that this patient is definitely in moderate respiratory distress and does need some form of oxygen therapy. We're going to assume that we've applied either a Hudson mask or a non-rebreather mask. And then we meet the patient again, and this is the situation. What would you do now? What are your thoughts now? Are you more worried about this patient? I guess so the questions are, I suppose, are you worried about the patient? And what would you do if she was presented to your emergency department or your ward? I'll give you a moment to write in the chat. Yeah, Team Naru, absolutely. She's gasping. She's definitely got nasal flaring, yes, which is a very real sign of severe respiratory distress. Any other thoughts about what you would do if this patient presented to your ED or was already on your ward? I think we would rightly all be worried about her. And we probably think about certainly escalating care, definitely asking for help, whether that be from one of our senior nurses or escalating potentially to one of the medical staff. Yes, Veronica, definitely providing reassurance and checking capillary refill and calling a doctor. Yeah, I think all of those are very, very reasonable things to do. And probably as nurses, we would also look for advocating to increase oxygen in this patient as well, whilst continuing to monitor her vital signs, as Veronica said. I mean, it's highly likely that she is going to need a high concentration of oxygen in the form of high flow. But how long can it take to organize to get an AVO ready in your health facility? It might be that there is an AVO there, but it hasn't already been set up from the last time it was used. It might be that the AVO is there, but it hasn't been cleaned since the last use. Or it might be that unfortunately not all of the consumables are available. So I guess what is important is knowing the availability of where you keep your AVO machines, where you keep your consumables. And I think often it's kind of often put on the nurses to know all of this stuff, which is great. But it's also probably beneficial if medical staff also know where all of these consumables are kept and where the AVOs are kept, and also how long it takes for us to get that AVO ready for use. Okay. Ooh. All right. So now we get on to the juicy stuff. So we've decided that the patient in the last video probably does require some high flow. What the next, I think, 3 slides are going to try and describe is how high flow works. And sometimes this can take a while to process and understand. I know it took me a number of months of thinking and working out and working with high flow to fully understand how it actually does work. So if we think about ourselves and the people in the same room as us at the moment, we are all hopefully sitting down comfortable, and our respiratory rate is normal. It's between 12 and 20, and we are not in respiratory distress. All right. So when we are not in respiratory distress, we breathe in at about 20 to 30 liters per minute of air. All right. So if there was a police officer with a speed camera and they were measuring the speed that air was drawn in by our lungs from the atmosphere, it would be about 20 to 30 liters of air. All right. Now, if you think about how you feel after you've climbed 10 flights of stairs as fast as you can, what's your breathing going to be like? And how are you going to feel? Wait a few moments for your answers. Team Nauru, how are you going to feel if you climb 10 flights of stairs as fast as you can? Exhausting, absolutely. And what about your respiratory rate? Is it still going to be normal? Team Nauru are onto it. So they've said that Team Nauru have said that their inspiratory flow demand is going to be more than 30 litres per minute after climbing 10 flights of stairs. You are absolutely correct, Team Nauru. Well done. If I had chocolates, I would give you some. So when a patient is out of breath, because they've exerted themselves through exercise or through illness, their inspiratory flow demand increases. Okay, now when we exercise and we feel exhausted for between 10 minutes or 2 hours, we know that our inspiratory flow demand will eventually get back to normal, okay, because we're fit and healthy. In someone who has a lung disease or who is in respiratory distress for a prolonged period of time, their inspiratory flow demand will not get better. It will be sustained at high levels. And that's where we think about our oxygen therapy. So with oxygen therapy, we need the flow of the oxygen to meet the inspiratory flow demand of the sick patient. So for example, if we have a patient that has a pneumonia and their inspiratory flow demand is about 50 litres per minute, we need to provide oxygen that meets that demand. So putting them on nasal prongs, which only delivers up to 5 litres per minute, is not going to be enough for that patient. Does that make sense? Because you've got a nasal prongs that can only deliver 5 litres a minute, whereas the patient needs 50 litres a minute. Please feel free, if you want me to go over that again, I can, or if you have any questions, please let me know. I think that probably one of the more complicated things about this theory is that as clinicians, without fancy machines, we actually can't measure inspiratory flow demand. But the way us as nurses know that a patient's inspiratory flow demand is increased is by looking at them, looking at their work of breathing. Are they working hard? Have they got signs of nasal flaring, intercostal recession, tachypnea? So all those are signs of an increased inspiratory flow demand. All right. So when someone is sick, they can have an inspiratory flow demand anywhere between 50 to 300 litres a minute. And when we've got someone that's sick with a flow demand of, 250 to 300 litres a minute, that's when we start thinking about invasive, non-invasive and invasive ventilation. All right. So what the next video is going to demonstrate is, so a patient, all right, with we're going to imagine this patient has a flow demand of, you can see here, 30 litres a minute, all right, and they're on a normal Hudson mask, a normal face mask, which is, we're going to say, is delivering 10 litres of oxygen. Okay, so this patient is getting 10 litres of oxygen through the normal face mask. This patient requires 30 litres of flow to match his inspiratory flow demand. So the other 20 litres of flow is coming from the air. So 20 litres of room air and 10 litres of oxygen gives us a flow of 30 litres per minute. Right. So that's the theory behind it. What happens with this patient is, even though they're getting 10 litres a minute of oxygen, this isn't enough oxygen in order to be able to oxygenate their lungs. So I'm just going to play what happens when you've got a little bit of oxygen, but not enough oxygen. So see, there's a little bit of oxygenation going on there in the lungs, the pink area, but probably not enough to maintain adequate saturation levels. So if we were to monitor oxygen levels on this patient, we probably would find that they were a bit low. However, let's move on to the same patient, but now we have provided him with high flow via the airvo. And we are giving him 30 litres a minute of oxygen and air. All right, so this 30 litres a minute matches his inspiratory flow demand. So they don't have to find any extra flow from the atmosphere. So let's see what happens to the oxygen being delivered to the lungs now that the patient is on high flow. A huge difference. So the result of applying high flow and meeting that inspiratory flow demand is that this patient will probably have better oxygen levels, but also their breathing hopefully will have slowed down and won't be as hard. So their work of breathing will have decreased. So in effect, high flow has two effects. The first one is it improves oxygenation. And the second one, because of the amount of flow that's being delivered, it can decrease work of breathing. Okay. Well done for getting through those 3 slides. Any questions so far? Just going to pause for a moment. Okay, let us continue on. Ta-da! Okay, so let's move on now to we've kind of had a very brief overview of how high flow works and the theory behind high flow. So now let's have a look at setting up the Evo. So this video was filmed in Fiji during COVID.
Bula Vinaka. So now we are going to set up the Evo in front of you. We've already disinfected the machine, which we have completed the 55-minute cycle. And with the red disinfectant tube still connected, now we are going to set up the Evo 2 machine. So we are opening up all our tubings. So we have the new consumable set, the adapter, the heater breathing circuit, and our water chamber. So we're removing the blue pot caps from the water chamber by twisting and pulling the tap upwards and outwards. Then we're removing the bracket holding the sterile water supply tube from the water chamber. So we're removing and discarding the red disinfectant tube. So now we're going to align the ports on the water chamber with the ports on the adapter. And then pressing down firmly to connect both pieces together. Align the 2 ports on the chamber with the 2 ports on the machine. So we're pushing the water chamber into the machine, and it should make a click when it's firmly in place. So once that's done, we'll attach the water supply tube spike into the bag of our sterile water. Cap on the side of the bag spike. And then we'll ensure that the bag sterile water is 20 centimeters above the humidifier. And we together also, while checking on this, we'll be checking to see if water is automatically filling into the chamber. If it rises above the water level line, then we'll need to replace the chamber with a new one. So once all that is done, now we're going to connect the heater breathing tube by sliding the blue circuit connector onto the machine. And when push down to lock, then the Evo 2 is now set up.
I think the Evo is a reasonably simple machine to set up with regard to the tubing and the consumables. I think probably the most popular question that's asked is to do with the cleaning in between patient use. And when you first turn the machine on, you get like a traffic light display. And basically what that means is red. If you get a red light on the traffic lights, it means that the Evo hasn't been cleaned and is not safe for use. If you get the amber traffic light, it means that the Evo has been cleaned, but it hasn't been used for, I think it's over 30 days and will probably benefit from another clean, but it potentially is okay to use. And then a green traffic light means, yeah, you're good to go. You can put this patient on this Evo. Any questions about the setting up of the Evo and any of the equipment that you need? No, I think the humidifier and the tubing all comes in one pack. Your nasal prongs come separately, and in different sizes. And then the only other piece of equipment that you will need is just oxygen tubing to go from the back of the Evo to your oxygen source, which I think is the next video. Oh no, sorry, this video illustrates how we change the parameters of the Evo prior to use. And it includes changing the temperature, the flow rate, and the amount of oxygen that is delivered.
Step 1. Switch on the Evo tube by pressing on/off button, first arrow for 5 seconds. If a green light appears, second arrow, then it is safe to use. If an orange light appears,
Oh, sorry.
do not use the Evo 2. Step 2. Set up the machine as per patient's prescription. Press and release mode button, arrow, to cycle between the 3 settings. Dew point temp, degrees Celsius. Gas flow rate, liters per minute. Oxygen saturation, percentage O2. Changing temperature, both up and down buttons together for 3 seconds. As shown to unlock settings. The padlock symbol will now disappear. Use up or down arrows to adjust temperature. Recommended temperature is 37 degrees Celsius. Press and release mode button to lock screen. Flow rate. Press and hold both up and down buttons together for 3 seconds as shown to unlock settings. The padlock symbol will now disappear. Use up or down button to adjust flow gas rate. Recommended rate 45 liters per minute. Press and release mode button to lock screen. Change to saturation. Turn the flow meter on the wall or cylinder to adjust the oxygen saturation. Use flow meter to reach desired saturation. Recommended O2 percentage is 50%. Step 5, while waiting for the machine to warm up, place the patient interface on. Ensure that the interface is free from touching the patient's ears. Step 6, wait for the ready to use symbol, arrow, to appear on the screen. Now connect the patient interface to the heated breathing tube. Push both tubes together until you hear a click. The patient will feel warm air coming through the interface. This is normal. Step 7, if using Evo on a child, press and hold the mode button for 5 seconds to activate the junior mode sign. To deactivate, press and hold the mode button for 5 seconds. Step 8, when using an Evo tool, always monitor the patient's oxygenation saturation, SpO2.
Oh, sorry, apologies. I've just realised that Team Nauru actually have you got an Evo there in the training room with you? Yes, okay, beautiful. If you have any specific questions as we're going through, please do ask. Or if you have any specific questions at all, happy to discuss at the end also. All right. So great that you have a machine there. So you can work with it in real time. Good work. Are we all okay to carry on? No objection. So I think we will carry on. All right. So this is probably one of the more complex things to understand when we're looking at oxygen and flow delivery with the AVO and how they interact. So some things to look out for are that when we are increasing oxygen delivery on the flow meter, this will obviously increase the amount of oxygen that's delivered. Okay. However, if we increase the flow on the AVO machine, this flow is atmospheric air being sucked into the machine. So if we turn up the flow and we're sucking more air in from the atmosphere, then the oxygen in the tubing will become more dilute. So the amount of oxygen we deliver will reduce. So this is really quite an important thing to understand, because it actually is, it's a safety concern that if we have a patient that is working really hard and we need to increase the flow on the AVO, we need to be mindful that when we increase the flow, the amount of oxygen being delivered will decrease. So in reality, what that means is we just need to keep a really, really close eye on our patients. And anytime we make any adjustments with the AVO, we monitor respiratory rate, work of breathing, and SpO2 levels of the patient. Because if we increase the flow being delivered, we may have to also, well, we will also have to increase the amount of oxygen being delivered. Now, hopefully this video will demonstrate that. There's subtitles to the video with some music in the background. But basically what I want you to look out for is that when we increase the flow on the AVO, watch what happens to your oxygen. And similarly, when we decrease the flow on the AVO, watch what happens to the oxygen. It will go up. All right. Right. So you may need to watch that video a couple of times. But as I say, I'll do a recording of this and post it on the NurseTOK Facebook page. I'm just conscious of time. So I think this is the last video. And this is about disinfecting the AVO after use and obviously in between patients. The key take-home message from this video is do not throw out the red tubing. It is like gold. If you throw that tubing out, you are unable to disinfect the machine in between patient uses. And they're really, really expensive to replace, as you may or may not already know.
How to clean and disinfect the AVO tool. Switch off the machine, unplug from the main. Then we remove the heated breathing tube. Discard. Remove the water chamber and sterile water bag from the machine.
Oh, sorry.
Discard. Remove the water chamber and sterile water bag from the machine. Once you've removed all the circuits, clean outlet elbow on the right. Dip sponge stick onto the mixture of warm water with approved mild detergent solution. Thoroughly clean the outlet elbow from both ends using a sponge stick. Rotate sponge stick while cleaning. You can always discard. Now clean the outlet elbow with a disposable cleaning lead-free cloth. Clean both ends. Continually rotate your finger while cleaning and go as far as inside as possible. You can always wipe outside the AVO tool using a disposable alcohol wipe, which you can later discard. Once all your cleanings are done, now we are going to disinfect the AVO machine. Using the red disinfection, which is red in color, so we'll disinfect the machine immediately after cleaning. So we insert blue end of the tube onto the top pot, push down to lock. Insert blue filter cap onto the right port. Once you've connected the red disinfectant tube, you may now turn on the machine, pressing and holding the mode button for 3 seconds. Again, if the air filter needs changing, the machine will promptly advise. If there are other prompts, notify the biomed while disinfection, while the machine is being disinfected. Once we've connected the disinfectant tube, the The machine will now automatically start the disinfecting cycle, which takes about 55 minutes. Again, if any problem occurs and the machine stops disinfecting, you can always restart the cycle. And if the machine keeps stopping repeatedly, we can always notify the biomed technician. So once the disinfection is successfully completed, it will show the disinfectant cycle.
So cleaning and disinfecting is actually quite an easy job. Lastly, if you're interested, there is a free app that you can download on your phones. And this is actually a really great educational resource. And I think in the interest of time, because I know you're all very busy people, and I know a few people have had to leave already, that's the end of the presentation. Are there any questions, comments, queries that anyone would like to ask? Whilst you're thinking of questions, oh, someone. I'm just going to run over hopefully what we have discussed during this session, and that's the discussion around the high flow devices we have in our clinical areas, which I think for most of us is the AVO. Explain how high flow therapy works, and also demonstrate the setting up, disinfection and application of the AVO 2. So that's it. Thank you ever so much for joining. Hopefully you'll be able to join again in the next NurseTOK, which will be in September. But in the meantime, please enjoy the rest of your days. I'm going to stop the recording now. But I've got one last request.